for the kind introduction and for having me as always. It's I was not too long ago, I used to be tuning into these sessions and learning from all the great faculty. So it's a real pleasure to be here and welcome everyone. My name is Shoaib. I'm a radiology registrar. So I'm an ST5 CCTing very soon at Guy's and St. Thomas's Hospital. And my subspecialty areas are nuclear medicine and cardiothoracics. But yeah, I'm very, very excited to be back. I've got some nice cases. And for those of you that tuned in last time, we have a new set of cases. There may be a few, one or two overlap, but the vast, vast majority will be new. So it's really nice to be back. What I'll do is I'm just gonna load up my cases. Okay, good. So do we have candidate one with us?
Yes, hello. Assalamu alaikum.
Okay, Sana. Thank you for joining us, candidate one. Just bear with me whilst I get set up. Okay. Just bear with me 1 second. The
No
internet's a bit
problem at all.
slow on my stuff.
It's okay, totally fine.
Okay.
Recording in progress.
Sorry, can you guys hear me?
Yes, we can.
Right, sorry, I think I just dropped off. Okay, good. I've switched my internet connection, so hopefully it should be fast now. Let's get to full screen. Good. So candidate one, whenever you're ready, please, can you take me through this AP pelvis radiograph? It's an elderly lady who's presented to the emergency department with inability to mobilize.
Okay, this is the full screen.
Yes, sorry, let me try if I can get it.
Okay, that's fine. I've been presented with AP projection of frontal projection of the pelvis, in which the first abnormality that catches my eye is actually a lytic lesion that is seen involving the region of the pubic symphysis. I'm not able to delineate or outline the cortical borders well in that area. Apart from that, I can see few metallic clips in the subcutaneous tissue, more centered upon the left side. And apart from that, there is generalized osteopenia, and the right SI joint appears mildly, what you can say, uh, widened. However, the left one I'm not able to appreciate well. Rest. Uh, I am in the upper femori. They appear grossly, the visualized parts appear grossly unremarkable. If there is any other view, I can see better the pubic bones, then I would like to see it and comment on them. So in these pelvic view, I can see that there is a redemonstration of this lytic lesion that is centered upon the pubic symphysis and involving the inferior pubic rami as well bilaterally. And so I would, considering an elderly female, my first differential in this case would be a metastatic deposit. However, I would like to correlate with the history of the patient and also advice for the MRI of the pelvic region.
Okay, so
And
let's see. So there's some more history because you've asked for more history. So the patient is actually, this is the true history. They were actually from Pakistan. They had a fall there 2 weeks ago, and they've come to the UK now, and they've presented to the emergency department.
Okay, so after the fall, this there appears to be the fracture of the inferior pubic rami on the right side, and also there is diastasis of the pubic symphysis as well. So I would like to further correlate this with the other images, and then
Who would you like
refer
to be
this for
next?
the orthopedic referral. Sorry,
Okay.
apologies for that.
No
Sorry.
problem. What would you like to do next?
I would like to see the CT
Okay.
if
CT,
available.
what specifically?
To see the evidence of the fracture and to see the outline of the fractures and any complications related to it.
So candidate one, you should be able to take over my screen to scroll yourself. Let's try and see if that works.
Yeah, sure. Yeah, I requested the remote.
Okay, I've approved it.
So I've been
So
presented with a
yeah.
CT scan. Okay. Am I scrolling? Yeah, I've been presented with the CT scan axial section post contrast images of the, I believe, chest first. So I'm just scrolling of a patient that has presented with trauma and the pelvic fractures. So I would like to first scroll through the images and then give my findings while it went down a bit. So, sorry. While okay, it is moving up and down. Maybe while I'm scrolling, the first abnormality that I noted was the presence of, uh, sorry, I think while
What's
I'm
happening?
scrolling it,
All right,
I
try
don't,
now.
I think I don't have the control now, maybe.
Okay, I'll
No, I
scroll for
do.
you. So if I
Yeah,
take
sure. Sorry.
back over, so if how do I relinquish? 1 second. If you just stop.
Yeah, sure.
Okay.
The image is very small. Can it be a bit bigger? Sorry.
Yeah. So let me see if I can zoom in for you.
Yeah,
Okay.
that's better. Yeah. While you scroll, I noted there was some embolus in the pulmonary artery. If I can re-see it, maybe there was a filling defect noted in the pulmonary artery.
Okay, so you want me to go back up?
Yeah, sure.
And
It
you
will
tell
be
me,
good if I can take the scroll. That will be much easier. I'll
just for
just
this
give.
case, just for this case, let me scroll. Tell me exactly what do you want to what do you want to see?
I want to see from top to bottom once
Okay. Yeah, that's what I was
slowly.
doing.
Then I will. Yeah. So there is evidence of fractures and with associated soft tissue component that is centered upon the pelvis. Uh, there is evidence of cortical breaks in the pelvic pubic symphysis bone and as well as in the posterior. Yeah, there is there is a destructive process that is seen involving the pubic bones as well as with associated soft tissue component. And as we go further up, the grossly the bowel appears unremarkable, and
So just focus on the
there is,
pelvis.
sorry.
Just focus on the pelvis, please.
Okay, I can see there is also involvement of the right iliac sacrum as well, and
You
yes,
can
there
ask me
is
to do whatever you
associated
want. Or
soft
you can
tissue.
ask me to do, you can ask me to do whatever you wish. If you want me to change window,
Yeah,
look for another
yeah.
views, etc. Tell me.
If I can see in the bone window, that will be easier. Yeah, there is a destructive process that is seen centered upon the bilateral pubic bones, and there is associated soft tissue component. And apart from that, I can see uh, in the left ala as in the left sacrum as well. I believe that they can be fractures as uh, it will be good if I can see them in coronal window. So further see them in a better fashion. So in the coronal views, which are centered upon the I can't see much. Uh, I can see that there is a fracture in there is a linear cortical break noted in the right side of the sacrum, and even on the left side, and with associated diastasis of the SI joints as well. There's
What do you think
and
is going on?
yeah, so I think uh, um, these could be the fractures associated to the uh, through the fall, but because there is subtle and considering the gross osteoporosis, I believe that there could be the insufficiency fractures in the sacrum, but there are also cortical breaks and fractures with soft tissue component, which was noted in the anterior part of the pelvic brim as well. So I have a strong suspicion that these could be the old insufficiency fractures, or and
Okay, so what do
but
insufficiency
as it
fractures normally look like?
like the insufficiency fractures um, uh, like they do appear in the form of a cortical break, but sometimes they are very occult, and
Okay.
they are better seen on the nuclear studies. So considering the history of fall, I believe that this is there are multiple fractures involving the pelvic bone, and as the patient has presented a bit late, so it might have exaggerated more in the sacrum,
How
and
would you
there was
describe this
but
fracture pattern?
like it's not the fractures in the sacrum are not displaced, but the fractures in the pelvic, they appears to be displayed and comminuted, and they are multiple, and they are associated with subtle hematoma or soft tissue component, which I
Okay,
would like to
I'm just
suggest
looking for the pattern of injury. So you've told me there's sacral fractures and a pubic symphysis fractures and kind of pubic
exactly.
remnant fractures. Do you know what you would describe that as?
Sorry, there are pubic symphysis fractures and there are sacral fractures. Yes.
Do you know how you describe that?
Yeah, there are, like, if it is if the impact is from the lateral side or anterior side, you're talking about that.
Okay, no worries, that's fine. And how would you explain the PE?
Pulmonary embolism is uh, yes, uh, um, well,
What do you think
I'm
happened
not
to this
sure.
patient? What do you think happened to? Do you think they?
Whenever there is a femoral, whenever there are fractures in the bones, the most concerning feature is of a fat embolism, but that doesn't look like this. That comes in the bones, but maybe I would like to check for the thrombotic state of the patient, and
Okay, no
that's
problem.
why, yeah.
That's fine. Thank you. Sorry, it was not loading. We'll let you. We'll try and let you take over screen for the next case. It was just a bit slow on this one. We'll go through it. This one at the end, but very good. Um, let's do this. Okay, so this person presents with finger swelling and pain.
Okay, I've been presented with the X-ray hands of bilateral X-ray of both hands, in which the first abnormality that I need is that I see is the presence of soft tissue swellings with calcifications, which are centered upon the first interphalangeal joint on the right hand side, in the ring finger. Sorry, in the middle finger as well as in the little finger, centered upon the first interphalangeal joints, and they form the subcutaneous swelling, and similar appearances of calcifications are also noted in the middle finger of the right hand as well. And they are centered around the joints, and similar smaller calcifix densities are also noted around the index finger of the right hand. While rest of the bones, like a couple of metacarpal joints and first couple of metaphalangeal joints and the visualized part of the wrist joints, they appear grossly unremarkable. So I believe that this is a case of calcinosis cutis. I would like to give a differential of, in this case, it could be calcinosis cutis, which is seen in the scleroderma patients. So I would like to inform these findings to the referring physician and ask for the further workup related to sarcoidosis. And other differentials in this case could be the calcifications because of the renal failure and tumoral calcinosis. These could be the other differentials related to this case. But the topmost priority will be to the scleroderma and the calcinosis cutis that is associated with scleroderma patients.
Okay. So what if I told you that on examination, this patient has no features of scleroderma?
Okay, so I would I would like to take the renal history, like the renal profile, whether he's a patient of any sort of renal failure, or then I would like to see the renal osteodystrophic changes in the bones.
There's no
And
evidence of renal failure.
there was no evidence of renal. So, is there any history of trauma and
Not sure.
sort of no? Okay, so uh, apart from that. Uh, I don't see any evidence of gross erosions or periarticular erosions or hanging margins to call them gouty lesions or profacious gouts. But I can put them in one of the differentials. But the typical features of periarticular hanging margins and erosions is not seen. And apart from that, I would consider myositis ossificans as well in my differential, but they normally appear in the form of sheets in the subcutaneous tissue. So I would like to have X-rays from the with similar subcutaneous swellings in other parts of the body, and then would
So
like
this
to
is the
proceed.
only part that's affected.
Okay, then um, uh, can it be SLE? Maybe like I'm just putting on the possible differentials
Okay, so
that are
that's
associated
fine.
with soft tissue calcifications. Yeah.
So just give me your final list of differentials, please.
So it could be on the top. I would like to put scleroderma, but like you have been saying, they are not in the. It can be scleroderma, it can be SLE, it can be due to renal osteodystrophy.
Okay. Okay, that's fine.
Yeah.
We'll move on from this case. Thank you. Okay, so let's see if you can take over this case.
Yeah, I requested.
You requested it. Let's see. Okay. Approve. So this is a lady with headache.
Okay, I'll try from there.
You know what? Just give me a second. Give me control back.
Okay. Yeah, I gave up the control.
Okay, now try and take control, please. Okay, hopefully this should work
Yeah.
now.
Sure.
So before you start scrolling,
Yeah.
what
Okay.
this is a lady with a headache. What sequence would you like?
T2 and then flare maybe.
Okay, here's your axial T2. Please scroll.
Okay. I've been presented with the CT MRI axial sections T2 weighted images in a patient in a lady who have been presented with headache. And the first abnormality that I note is the presence of periventricular focal T2 high spots in the periventricular region near the semi-whale. Apart from that, if I scroll down, I'm not able to appreciate any gross abnormality in the parenchyma. And I would like to go to the last edge, and the upper cervical cord appears intact. There is the CP angles are normal, and considering these features, there is no evidence of any gross hydrocephalic changes or any mass effect or any abnormal dilatation of intra or extracellular spaces, and the bilateral orbits appear intact. So I would like to see the flare, sagittal flare, if I
Yep, you
can.
can bring up the flare, so you can see it there. It's right. It's at the bottom of the
Yeah,
list.
this one.
Sagittal. No, the
This
one
one.
just below it. One below it. Sagittal
Okay,
T2
this
flare.
one. Okay. So while I would like to scroll then and again.
Yeah,
So
please
while
do.
I'm scrolling, I would like to reevaluate those lesions which were previously seen. And now I can see that in the FLAIR coronal images, there are a bunch of them which are present in the temporal lobes as well, and in the previously noted periventricular white region. And there, some of them are oriented perpendicular to the periventricular region, giving the appearance of Dawson fingers. And they are seen in bilateral cerebral hemisphere in the subcortical regions, randomly distributed. And considering these features of headache and these features, I believe that this is a case of demyelination, likely multiple sclerosis. So I would like to see the diffusion weighted to see if there is some of them might be restricting that basically shows the
Okay,
activated
that's fine. You can open up the
demyelinated
diffusion weight.
lesions.
You can open up the diffusion weighted imaging.
This one, maybe. This is ADC. This is
Oh,
diffusion. Okay, I
yeah,
think, yeah. Okay. So these are the diffusion weighted images, and I can see that none of them, yeah, there is a lesion and the right occipital region that show subtle increase TW value, T value. And apart from that, I am not able to appreciate any rest of the lesion which appears to be, there are a bunch of them which are seen high on the near the corona, in the region of the corona radiata as well. So this might suggest the active lesions, and I would like to see them in the post EADC map as well as in the post contrast images to delineate that whether this is an active these are the active
Okay.
this is an active
You can
episode
have a you
going
can
on.
have a look at the post contrast imaging. Don't worry about the pre contrast. You can
Okay.
have a look at the post. So
Yeah, they are certainly enhancing as well, especially the largest one, which was as noted in the right occipital region. And
okay,
it's
keep.
stopped
Are there are there are
scrolling.
there, are there any other lesions?
Yeah, the one in the temporal lobe as well. And apart from this, I would definitely like to have a scan of the neuroaxis to see associated lesions in the cervical spine as well.
Okay,
And
fine. Is
there
there
are a
anything
few
else
of
you'd like a scan of?
I would like to see the orbital nerves as well to see that there is no associated optic neuritis,
Okay,
underlying optic
what
neuritis
sequence
going
would
on.
you like?
I have T2 coronal fat sac, 3 milli.
Uh, okay, let's see. I think we've got a coronal stir of the orbits at the top, right at the
Yeah,
top.
sure. Yeah.
So if you open
Uh,
that up,
it, coronal stir, okay.
yeah.
Coronal stir, this one. Yeah, okay. So as I'm scrolling to the coronal stir images, yeah, I can see that there is okay. I would like to window it a bit, but the donut sign appears to be intact on the right side. But I believe that there is loss of central low signal on the left side. So there might be some element of optic neuritis. I would like to see it in the post contrast images as well to see if there is associated enhancement of the optic nerve as well.
Okay, you can look at
But
the coronal. There's a coronal post contrast,
okay.
and there's also an axial post contrast of the
Yeah,
orbits.
axial will be better. This is axial, I think.
Yeah.
Okay. In the axial post contrast images, I want to center more upon the optic nerves. Uh, well, I don't see any gross avid enhancement, but I would like to refer this patient. There is subtle enhancement noted along the chiasm and in the orbital region, in the orbital apex, more so on the left side, I
Okay,
believe.
that's fine. And
So I would,
okay, that's fine. Let's move on. If you look at the MRI spine, please.
yeah, sure. It's down
So if you
or up.
stop. Let me see if I can do it. So just stop moving the
Sure.
mouse.
Yeah.
Which sequence would you like?
A T2 stir.
Okay, you can scroll.
Okay, I've been provided with the T2 stir images of the cervical spine. And here I can see that there is evidence of T2 high, stir high lesions in the upper thoracic cord, and they are intramedullary. And apart from that, I'm not able to appreciate any other lesion. So no, there is another noted at a higher level from this. So I would reconfirm them in the axial images, and then I
Okay,
think that this is a
you can reconfirm them.
yeah, okay.
Yeah. Oh yeah, yeah.
Yeah, there was one lesion that I noted just here. It was in the center of the cord intramedullary, and it is a short segment high signal lesion. I think this is the last. Going further up, uh, I uh, I think this is a
Okay,
limited section that is centered upon
that's
the
fine.
lesion that was. Yeah. So to
Oh,
conclude, yeah.
no, continue.
Yeah, to summarize, this is actually a case of multiple sclerosis with the bilateral periventricular high signal foci with suggesting Dawson fingers as well. The one with perpendicularly oriented, with some of them showing restricted diffusion and post contrast enhancement, suggesting that they are the active lesions, and with associated lesions noted in the spine as well, and also with the suspicion of optic neuritis. So this patient, I will inform to the referring physician and ask for the neurosurgical consultation immediately, because if there is underlying optic neuritis, he needs immediate treatment.
Okay, and
And also,
what's your differential here?
uh, differential could be neuromyelitis optica in this
And how
case.
would you differentiate the two?
But neuromyelitis optica predominantly affect uh, uh, the base of the optic chiasm more, and it affect the brain stem, and they do not affect the periventricular white matter, like the lesions are not like typical, and the periventricular lesions are not typical like that of those of MS, and also the lesions are longer in the spine as compared to the one which we have seen for the MS.
Okay, good. Let's just stop there. So well done. You can relax. You can breathe now. That's very good. I've got control
Thank
of the
you.
screen. So I know it's always difficult doing this in front of people and doing it live. So you've done very, very well. And we're just going to go through the cases now, okay? So we can get your session feedback and everything done in good time. How did you find it?
Well, I think I didn't do well in the first case because I think maybe because I
Yeah.
was not able to scroll myself.
Sure.
I believe when I scroll myself, I can see the things better
Yeah,
because
it's always a bit tricky. Sorry. So let's go through the first case. People in the chat can respond now because obviously the vibe is over. But I think some starting off with general feedback. I think it was very good. You were always on the right track, but I think to take things to the new level, slow down. You talk fast and you say a lot of things in a short space of time. I would always I always say for any exam you do, so I teach obviously in radiology exam, but I also teach them some other exams. And what people do is they make the mistake of speaking too much and digging themselves a hole. As someone who's watching you, I want to hear less but more accurate. It's better to be accurate and say less than say a lot and be, have the risk of saying things which are wrong. So when you looked at this, just give yourself 20 seconds and you can tell the examiner just saying, thank you. Always say, I'm now looking at an AP radiograph of the pelvis. I'm just going to have a quick look. Okay. And then the examiner knows, okay, you're looking, just give them some time. You don't need to dive in straight away. So right away you can see there's diastasis. So this is a real story. The patient came in from Pakistan, 2 week history. They were immobile. I don't think they were really seen or they went sought medical care when they were abroad and they came to this country. They live here and they were immobile. They were not mobilizing. So their family brought them in. Obviously, they're quite worried. It was an elderly lady. And A&E came to me and said, this pelvis radiograph looks weird. Do we need to do something? So when you look at this, there's diastasis of the pelvis. So I mean, you're right. It could be a destructive process, but with that history and diastasis will normally cause erosion, but you can see there's pubic rami fractures as well. So this could be destructive, but with that history and maybe a bit of widening here, of the SIJ, which you rightly picked up on, I think you need to think immediately that this is a traumatic injury and a high mechanism of injury. And I was trying to push you on the CT to tell me what the pattern of injury is. So you literally described it and opening it up to the chat. What is this pattern of injury?
Is it AP compression?
So this is an open book fracture, okay? So when you have anterior and posterior pelvic ring involvement, let's just scroll all the way down. So I know it's difficult because you are on. So there's bilateral sacroalar fractures, displaced, yeah. And the thing about this is I think you started saying it was insufficiency, but just remember the history, right? It's there's a kind of a vague history of trauma. We're not really sure. It sounds like there's some trauma. But I know you probably just said this in the heat of the moment, but have you ever seen insufficiency fractures which look like this? Because normally insufficiency fractures are occult on CT and you need MRI or nuclear medicine to see them, right? And if you do see them, they're often like faint sclerosis. It will just look like a subtle, almost think like a stress fracture in the foot. You have to look really hard to see them. This is a very obvious bilateral sacroalar fracture. And then you've also got widening of the pubic symphysis. You've got these comminuted inferior pubic rami fractures. So there's anterior pubic pelvic and posterior pelvic involvement. So this is called an open book fracture. And the reason you're seeing all of this soft tissue, that's just hematoma. It's not really a destructive lesion, okay? So this is
Yeah, yeah.
hematoma
I think
situ.
I mentioned that might be a hematoma.
Yeah, sure. So this isn't because why this is not a destructive, aggressive process. This is not a cancer, is the point, right?
Not
Um,
destructive, right? Yes.
Yeah, but it can look like that. You're right. Like, if you just look at this, but you're putting it all together, why would, because then why would, if this was cancer, why would they have bilateral sacroalar fractures, right? It doesn't quite fit. So this is an open book fracture. And then I asked you, why does the patient have PEs? So what I was trying to get at, and I think you got sidetracked here by telling me the patient could be thrombotic, but why are they thrombotic in this case? What do you think? Do you think they're able to mobilize?
Yeah, likely because of the long flights, maybe he has developed the
No, so
PVT and then
always remember the history. So this is why you have to. So a
you
really
flew
good
back to
character.
Pakistan. You said you flew back from the Pakistan, so eight
Just
hours
let me,
flight.
yeah, just
Yeah,
let me finish. So always go back to the history. It's a 2 week history of vague history. There's some vague, maybe there was trauma 2 weeks ago. So this patient has probably been lying around in bed, not moving at all for 2 weeks. And as you said, rightly so, there was probably also an added long haul flight. And then they've come to England and they've also lying in bed. So there's been a long period of immobilization, which in an elderly patient with pelvic fracture, this is all just, asking for disaster. Um, so yeah, that's the cause for the P's most likely. Of course, we can never know, but most likely this is going to be the cause. So to really hit those high marks, it's always nice to tie it back to the history, okay? But you picked up the findings, it's just characterizing them, which could have, you could have done better. But I know it was difficult because I was scrolling. Do you have any questions on that case?
yeah. Regarding the management, like what should be mentioned in such cases? Like it should be an emergency, or like can you just tell us about the management?
Sure. So open book fractures are high, suggests a high mechanism of injury. So in this case, it would typically be managed by a trauma team or orthopedics, right? So that's all you need to say. So like I would alert EDs, this is an emergent finding. I would let them know about the PEs. And the key thing there was right main pulmonary artery involvement. So these are like significant clot burden. So I'd let them know that there's significant clot burden. And you need to say if there is or is not evidence of right heart strain. Whenever you see a PE, there's certain things in radiology, right? So if you see a PE, think heart strain. If you see pancreatitis, think perforation, think pseudoaneurysm, think portal vein thrombus. So it's just one of those triggers. PE, is there or isn't there heart strain? Um, and then there's a open book fracture. This needs to be managed by orthopedics. Okay. And then I'll just leave it at that. But good question. So this case was tricky. It's a bit vague. Does anyone know what this is? And you mentioned the diagnosis. Just opening up to the chat again. Okay, so this is tumoral calcinosis. So I think you said calcinosis cutis and you went down scleroderma route, but I can see why you said that. So these calcifications are very much focused, they're periarticular, as you said, and the dystrophic. So yeah, I mean, calcinosis cutis is a reasonable differential, but this is solely focused around the kind of joints. Um, and there's no evidence of arthropathy, there's no erosions, there's no evidence of kind of anything else going on here. So the differential, it is a differential case, but I think tumoral calcinosis needs to be up there. Myositis ossificans, you mentioned, it's true that is a potential differential, but the calcification myositis ossificans doesn't really look like this. You typically get like this circular linear calcification with a lucent center. Um, so given that it's so focused around the interphalangeal joints, and there's no joint involvement whatsoever, uh, tumoral calcinosis needs to be one of your primary differentials. You did mention it, to be fair, and you mentioned some really good negatives. So you told me there's no joint involvement, which is a really important negative. The other things I would say is just ask for other views. It wouldn't have helped you really, but like they are there, and it's just good practice to always say, is there anything previous? Um, or are there any other views I can see? In every case, I would just get in the habit of saying that. Okay. What about all right, trying to get out of this. Fine. And then the next case. So I think you knew what this case was straight away, right? Candidate one, are you still there? Okay, I think we might have lost candidate one. That's fine. We'll quickly go through this.
No, sorry, I'm here. Sorry.
Oh, okay, fine. So I think you knew what this was straight away, which is
Yes.
good. I would say in any MR brain case, usually I would ask for the flare first because the flare sequence highlights where the abnormality is. But it's okay. You asked for axial T2, which is very reasonable. So as you said, there's again in this case, I think there was two. You be more succinct and get to the point quicker because you did brilliant. You knew what the answer was, so I would keep it brief, right? Don't keep talking because you'll end up saying things which are wrong. So I would just say the supra and infratentorial, linearly oriented, deep white matter, high signal, particularly centered at the periventricular region, dorsal finger morphology. This is in keeping with a demyelinating disease. I'd like to see diffusion weighting and post-contrast imaging. Okay, just keep it brief, short and sweet, because I mean, you can say, let's talk about the distribution as well. That's fine. But there were a few things which you said which didn't sound quite right. So I think you called these T2 high spots. So I wrote that down. And also on the diffusion weighted imaging, you said these are um, you called these high B value. So this is a high B value image, but in terms of you describing this, just say, high signal on the diffusion weighted imaging. Just keep it
Okay.
simple. And
Yeah,
I
sure.
think you mainly picked up on this one, but there were multiple which were actually, as you can see, it's quite
Yeah.
faint. But there are multiple which have high signal. And similarly on the post contrast, I don't think I showed you this sequence, but there are a few which are
But
enhancing. Yeah. So remember to diagnose multiple sclerosis, as someone has said in the chat, you need to disseminate it in time and disseminate it in space. So we know it's disseminated in time because they're enhancing and they're non-enhancing lesions. And we know it's disseminated in space because obviously there's multiple around the brain. Um, and that's called McDonald's criteria. It's important to know that because if you want to look impressive, you can say that in your VIAP. You can say there's multiple lesions disseminated in time and space. This fits McDonald's criteria. It's in keeping with multiple or demyelinating disease, such as multiple sclerosis. And then we had a look at the coronal stir imaging. So which is the abnormal optic nerve? So just putting this to the chat. So it's this bright stir signal, yeah. So this is the optic neuritis over here on the right side. That's abnormal. That was the only thing. The other thing is on the MR spine, I think we kind of were running out of time a little bit here, but you picked up. So what I would say is for demyelinating lesions, always correlate them on stir and T2 because sometimes on stir you can get like bright spots which are just artifact. This is obviously not normal, but you ideally want to correlate it on the T2. Do we have a T2? You can see there's kind of these faint areas of signal change here and here. So this is a genuine demyelinating disease. And I asked you about neuromyelitis optica versus um,
MS.
MS, and the key thing is neuritis optica has a predilection for the uh, optic nerve, and it typically causes long segment changes in the spinal cord. Okay, so MS typically causes changes over one or two vertebral levels, whereas NMO causes changes over multiple levels. So the way you could say is this is most in keeping with MS. And then if you want to look really smart, you can say, I'd advise a neurology referral, and this patient should have a lumbar puncture to look for oligoclonal bands. They can have, you can start mentioning a few of the investigations. If you're going down the NMO route, you can say this patient can have antibody testing for aquaporin 4 antibodies, just to make yourself look a little, like you really know your stuff. But you nailed this case. You knew it was multiple sclerosis, which was very good. Do you have any questions before we finish up?
Yeah, related to the optic neuritis, like, isn't it that there should be the loss of central low signal that is actually forming the nerve, because the peripheral one is formed by the optic sheath. So the signal was preserved, wasn't it? In the
Let's
axial
have a look at the post contrast. I don't think we've got all of the sequences here, to be fair.
not in the post control, in the T2 stir,
Yeah,
like
we'll have a look at that as well.
it is called loss of donut sign, something like this. Like,
Where have we got those? Oh, here we go. Renal post contrast. Okay, let's try and revisit this one at the end because I just want a bit more time to actually look through the sequences properly.
yeah, sure,
But yeah,
sure, sure,
that's
sure.
fine.
Thank you so much.
But
Thanks for your
no, no,
feedback
no
and
problem.
thanks.
No problem. Good. Let's just stop there. So what I'm going to do is we're going to have a 5 minute break and then we're going to return with candidate two. Okay. So I'll be back in 5 minutes just for a quick break and we'll crack on with candidate two.
Candidate 2C.
Brilliant. So well done, candidate one. That was really good, and it's always hard going first up. Sorry about the scrolling issues from my end. So do we have candidate two with us?
Yes.
Welcome, candidate two. We'll just get straight into it. So we will go with, just need to make sure I pull up the right case. Yeah, okay. Fine. I think that's... Okay, so candidate two, can you take control of my screen, please?
Yeah, I will ask.
So, 1 second.
I
Yeah,
will
sorry, I
start.
rejected it. I'll give it to you again. Don't worry. Okay, so you should have control. You might need to just go to the pan function at the top. So I'll just do that for you. So stop moving the
Okay.
mouse. Don't move, don't click anything, please.
Okay.
Okay, go for it.
Okay.
Your time starts now.
Uh, just I don't know the history. I will.
Sorry, yeah. So it's a young person with abdominal pain.
Okay. Sorry, young female or me?
I'm not sure.
Okay, I will check. No problem. This is CT axial cut abdomen with portovenous phase. Just I will have a look and then I will comment. Okay, appear to be female. Okay, now I will. This is a female patient with uterus. While I'm going up, I can notice that there is evidence of BIUCD noted within the uterus, but it appears to be in abnormal position. I will go up. Okay. I can appreciate that there is evidence of some soft tissue nodules noted, cutaneous soft tissue nodule. While I'm going down, I can appreciate that there is evidence of some fat stranding noted within the mesentery. And I can notice also that there is evidence of abnormal lesion noted here with hypointensity. Just I wanted to trace it. Okay, there is evidence of fluid, mild fluid noted within the abdomen. Thickening of the bone and narrowing of the lumen appear to be mildly enhanced of the bowel loops. Just I wanted to trace this abnormality in the middle of the abdomen.
When you look at so open the 2 mm slices. So if you stop moving the
Okay.
mouse.
Okay.
Okay, just give it a second to load. Okay, try this now. Maybe that'll help you.
While I'm going down also, liver and pancreas, both kidneys appearing normal. Yes, I wanted to really appreciate or delineate this lesion because it's not okay. It appears to be low dense lesion, could be fat content. However, I couldn't really appreciate any bowel loop dilatation.
Okay. So what do you think is going on?
Um, I wanted to, yes, here.
So focus on that lesion that you told me
Yeah,
about.
this
So what?
could be because I can delineate here, maybe lupus bowel lupus other in this region could be intersusception due to of lipoma in the, but there is no yet, there is no evidence of intestinal obstruction, but I can really appreciate here in this region, which appears to be maybe lupus loop.
Okay, I mean it's possible, but I think focus more on the lesion. Don't worry about the don't worry about
Okay,
interception. Yeah.
okay. I am trying to trace it because I really, um, it appears to be in the small bowel loops, but does not cause any obstruction. And with this low density, which may be fat density, and this hyperintensity also may be post-contrast enhancement content also within it.
So I'll tell you it's fluid
Uh,
density. When you measure it, it's fluid density, okay? The Hounsfield unit is about 10.
Okay, okay. So if it's a fluid density, it could be also new. It could be enteric cyst within the small bowel loops.
Okay, is there anything else you think it could be?
I'm trying to. Yes, I can appreciate that there is evidence of a spiral sign also noted here in the mesentery of the in the vessels of the mesentery in this region with fat stranding surrounding here. Yes, yes. Here in this region there is evidence of
Yeah.
spiral
So what do you think
sign.
is going on?
Maybe there is um, I couldn't say midgut volvulus. It could be uh, it could be even the blood. It could be volvulus noted here within the mesentery of the vessel, or
Okay, let's stop there. What do you think the lesion is?
lesion could be, if this is fluid density, it could be enteric cyst. Could be enteric cyst within the small bowel.
Okay, that's fine. And what would you like to do next?
Uh, I want to look even for coronal view. Maybe I could trace it well before I am. Can I
Okay,
look for?
I'll take control and I'll show you it on coronal. Okay.
Okay. Okay.
Does that help you?
Uh, just I wanted to see. Appear to be cyst with the neural nodule or enhancement in this view.
So what's your differential for this? You told me you're enteric cyst. Is there anything else you think it could be?
It could be uh, with this neural nodule, it could be maybe a gist tumor, maybe a lymphoma in the wall of the intestine also. I'm really not sure about this, but
Okay, that's fine. So let me show you the MR abdomen. I'm not expecting you to know this in depth, but I'll pull up a few. I think I only have one relevant sequence. So let me see. So this one. Sorry, not all of the ones that I wanted came through. Okay, so I'm going to scroll through this and tell me, what do you notice?
okay. I will look for the lesion. It appears to be, this is T2 MRI. There is evidence of fluid level within the lesion,
Where
or
is the lesion? Tell me.
just here in this one.
I can't. Well, you have to describe it. Where?
Okay. This lesion was fluid level, but it appeared to be in the right side, in the left side, sorry, in the CT, but here, okay.
Okay. Um,
Can I look also, maybe there is also abnormality in the uterus?
don't worry about the uterus.
Okay.
So what do you think this is?
So this is the same for the CT, but it was in the CT in the left side, but here it appeared to be in the right side. Was fluid level. I really
Okay, you told me the patient had some subcutaneous nodules. What do you think? What
yes,
do you think that is causing that?
subcutaneous nodules. Um, could be neurofibromatosis type 1. Could be
So if I tell you that you're right, the patient has neurofibromatosis type 1, does that help you?
so neurofibromatosis type 1 could be associated with multiple lesions in the intestine. It could be in the abdomen, sorry.
Okay, do you know anything specific? Do you know of a specific association?
Yes, it could be associated with pheochromocytoma. It could be associated with
Okay, no problem. Let's stop there. So we move on to the next case. Okay, so this is you still have control, so that's fine. But for this, you don't need to scroll, obviously. It's an AP pelvic radiograph of a patient with pelvic pain.
okay. 80, sorry, the age is 80 years old. 80.
Yeah, they're elderly. I don't know the exact age, but we can say it's an elderly
Oh,
patient.
elderly. Okay. Just I will have a look for the this is frontal radiograph of the pelvis for mature skeletally patient. Just I will have a look for the X-ray and then I will comment. Just I couldn't really appreciate something clear in the X-ray. Both sacroiliac joints appearing normal, both iliac bones also appearing normal. I couldn't appreciate abnormality within them. When I am looking for the both pubic ramus, also they appearing normal. Head of femurs appear normal.
Okay.
Just I can see maybe there is a lucency in the proximal shaft of the left femur, or this in this region.
Okay.
It appears to be lucent, extending in the proximal shaft. However, I couldn't really appreciate if there is no evidence of pathological fracture noted related to it, and it appeared to be slightly with wide zone of transition.
Okay. So
I could
what's your differential?
in this age with this lucency, it could be multiple myeloma, it could be MIPS, it could be also lymphoma.
Okay. What would you like to do next?
Next, I would like to go for MRI for this patient. And for sure, I should compare with the previous and ask about the history of the patient if he has any history of cancer. And
Okay.
after this, I want to look for MRI for this patient.
So you want an MRI of the pelvis?
Yes.
Okay. That's fine. Well, let's have a look at the CT because I don't have an MRI unfortunately, but we can have a look at the CT. So here you go. You can scroll through.
Okay. This is a CT for neck and chest. Can appreciate that there is a multiple hypodense lesion noted within the liver. I will go down just to complete the cuts and then I will comment. Okay. The CT does not involve maybe I want to look for the lesion also in the bone window. However, I will just go first and look for the main finding. Okay. In the liver, I can appreciate that there is evidence of multiple hypodensity scattered through all the liver parenchyma. the large one, it appears to be in the related to the porta hepatis and related to the left lobe of the liver. Just I wanted to have a look for the gallbladder. The gallbladder appearing slightly dilated.
Okay, so try. Okay, continue. That's fine. Where do you think the primary is?
Um, I am trying to look for the primaries. I couldn't really appreciate spleen appearing normal, both kidneys appearing normal, and I couldn't find. I wanted to look and trace also the intestine. I wanted to exclude the colon cancer, or if there is no colon cancer, this could be also a cholangiocarcinoma in the liver. I'm thinking of, and also I wanted to look for the pancreas.
Okay, the pancreas is fine. Just scroll up.
Okay,
Have a look. Yeah, keep going.
okay.
So what do you notice in the thorax?
I will check. I will check also the head and the neck if there is any
That's
evidence
fine.
of.
Look in the thorax, please.
Sorry.
Look in the thorax. What do you think of the
Okay.
thorax?
Okay. There is evidence of thickening of the esophagus, enhanced soft tissue noted within the esophagus, circumferential.
So
Mostly this could be
what do you
cancer
think?
esophagus.
Is that the esophagus?
This is the esophagus. This one. This one.
Mm-hmm.
Okay.
What do you make of the surgical clips?
Yes. So it could be surgectomy with gastric pull-up, maybe, because I really couldn't appreciate the stomach here. So, or it could be surgical remove. Yes, this is the stomach, and there is evidence of surgical clips noted here. So, could be this is post-surgectomy,
Okay.
but
So what do you
here,
think is going on then?
but so this could be cancer post-surgectomy and mets in the liver and in the
Okay, and
bone.
have a look at the bone lesion that you showed me. Let's just stop scrolling. I'll put it on bone window for you.
Okay,
So have a look at the bones now and let me know what you notice.
okay. I'm just looking for the spine. There is evidence of lytic lesion also noted in the left iliac, in the right, sorry, in the right iliac bone. And again, the lytic lesion that I noticed in the left femoral shaft.
Mm-hmm.
Okay. But this is in the, okay, it's lytic here. I'm just trying to look if there is any other abnormality in the bone.
Okay, you can have a look at the spine. Have a look at the spine, please.
Yes, I will go up. Okay, sacrum appearing normal. The spine also show lytic lesion. Here. And there is some sclerotics also, some sclerotic lesion also noted. Okay. Multiple lytic lesions within the spine.
Okay, that's fine. Stop there, please. Thank you. Stop
Okay.
scrolling. Good. Okay, fine. So this patient, I think this is a CT aortogram. So they present to A&E with chest pain. But what I want you to do is I want you to focus on the lungs, okay?
Oh, scrolling. Okay. It's not scrolling,
Yeah, just give it
just
a second.
jumping. Yeah, just jumping. Yes.
Okay, just stop scrolling for a second. Yeah, just give it a second to load. 1 second, sorry. I'm just making sure it's okay. Most of the thorax is loaded now, so you can scroll through that.
Okay. This is a CT, lung window, axial cuts. I can appreciate that there is evidence of multiple cystic lesion scattered through both the lung parenchyma. Just I wanted to evaluate the distribution. They appear to be extended through all the lung parenchyma. However, there is sparing also for the costophrenic angle. And the sparing also for the apex of both the lung. While I'm going, I can appreciate that there is increase the opacity in the right lower lung zone as a nodule. Just I want to know what is this patient coming with?
They came with chest
What
pain.
is the history? Chest
They
pain?
came to A&E with chest pain, and that's CT, A&E want to rule out an aortic dissection.
Okay. Okay, the aorta appearing normal here. Even I shouldn't comment on it here, but just this is scattered cystic changes through both the lung parenchyma and sparing the costophrenic angle and the apex of both the lung.
So what do you think is going on?
It could be cystic lung disease for this patient. Maybe if he has a smoking history, it could be LCH for this patient. It could be also, but this patient is appear. I didn't check if she's female or male, just for. Okay.
Okay, so what
Could be other just cystic lung disease like lymphoid interstitial pneumonia.
so
But
which one do you think is most likely here?
hmm?
What
uh,
cystic lung disease do you think is most likely here?
Mostly LCH because it is the one that is sparing the costophrenic angle and the lung apex.
Okay. And what would you like to do next?
Just I wanted to know the history of this patient, if he has a smoking or no. I want to look for the mediastinal window also.
Okay, I mean, there's a few reactive nodes, but nothing specific in the mediastinum.
Okay. I want also to exclude if there is any evidence of 3M, but maybe on top infection of this.
Okay, that's fine, but you can see that, right? You don't when you say you want to exclude
Yeah.
tree and bud, you can see there's no tree and bud. So what would you like to do next?
Just I will compare with the previous and correlate with the history of this patient.
Sure, so there is no
And
previous.
no previous. Okay. And no history. No previous and no history for smoking, maybe. Okay.
What do you think of the nodule?
If this is smoking history also, I would be very concerned about malignant nodule. If there is any smoking history, I would be concerned about the malignant nodule.
Okay, what if they're not? What if there's no smoking history? You're not concerned?
Um, sorry.
If they're not a smoker, are you not concerned then?
Uh, yes. Again, if not smoking, I will concern yes. This nodule
Okay, so
appears
what would you
to
like to
be
do next?
slightly. At least I wanted to do CT staging. I wanted to look for the abdomen and the pelvis. Maybe there is a primary for this nodule, if this is
Okay.
not the primary here.
So you've told me this, you think this patient could have LIP. So what do you think this nodule might be?
If lymphoid interstitial pneumonia,
Yeah. So what do you think the nodule could be?
um, could be um, I don't know really.
No problem. That's fine. Let's stop there, okay? Very good. How far are we in? Let me just check my timer. Okay, so we're 23 minutes in. So let's stop here, and we will go over the cases, okay? So let me take control of the screen. How do you feel that went?
Very bad,
Very good?
very bad.
Very bad. Oh, sorry. No, not at all. I would completely disagree. I was very good. Just like candidate one, you did very well. You had I think what you both did really well is you kind of pick up on the findings. Definitely there's some techniques and things that you can work on, but no, I wouldn't say went very bad at all. I know it always these things always seem worse than they actually are. And in your exam, you almost certainly, and trust me, you'll go into the exam, you think you probably failed it, but you won't. Hopefully, you won't have done it. It's just as humans, we always kind of pick up on our bad points and we don't focus on the good things. You did very good. Let me see, what did we start off with? We started off with the abdo case, didn't we? This is a really difficult case, actually. I was thinking of whether to put this in or not, because it is a bit niche, and I just thought it was a really interesting case, which is why I put it in. The FRCR exams changed now, so before examiners would just bring along whatever cases they wanted, and whatever interested them. Now, it's all standardized, which is a good thing, which means you're probably not going to get something super niche. So you might not get this, but it's still useful, I think, because in the exam, you're definitely going to come across things which you haven't seen before. So does anyone know what this is actually? This is a very challenging case, and I still think they're working on the diagnosis, but there's definitely a top differential here. So this patient, right, has these multiple, which you did very well to pick up on, because to be honest, I think it's very easy to not look at the skin. They've got multiple soft tissue nodules. I told you they were young, and I think you worked out they were female, but this patient has got NF1, okay? So these are neurofibromas. So there is an association. I've not heard of this association until I saw this case and looked at Radiopedia, but there is an association between GIST and NF1. So this is a GIST. This is most likely a GIST, okay? So it's a mixed solid/cystic mass which is coming off the jejunum. If you follow it around, it's proximal small bowel, okay? So you've got some jejunal loops here, where basically if you follow it around. So this all here is proximal jejunum, and you can see this lesion here is coming off the small bowel. So this is all small bowel here, right? Small bowel, small bowel. This is small bowel, and this whole thing is the lesion. So I wonder, can I draw?
Exophytic.
Yeah, exactly. Yeah. So it's this whole thing is the lesion. So it's like a dumbbell shaped exophytic lesion with a solid enhancing component and a cystic component. So I think this is the bowel coming in here, and it comes around, and you can see this is the lesion, and you can probably appreciate it a little bit better in coronal. It's a tricky one. Probably need some. Yeah, can you see this is the bowel here, and the bowel curves around like this, and off of this bit of bowel, you've got this figure of 8 appearing exophytic lesion. It's got a solid component here and then a cystic component. So GIST can sometimes have a solid component as well. The point is, if you see a cystic lesion in the GI tract, you need to have a differential. So don't make it complicated. Just think, okay, cystic lesion coming off the GI tract. This could be a GIST. It could be a neuroenteric cyst or a duplication cyst of some sort, but you wouldn't get the solid component. So that's less likely. It could be an adenocarcinoma. Or it could be lymphoma. So lymphoma is not typical for lymphoma. Lymphoma is normally encases the bowel, But when it becomes necrotic, it can become cystic. So that's the other differential. But this is most likely a GIST because it's exophytic and it's partly cystic. So GIST is your top differential here. The weird thing in this case is the swelling of the mesentery. So there's not really a huge amount to explain that, and that's a bit of a red herring, but it is there. The SMA-SMV axis is inverted, and if you look on the subsequent MRI, the lesion is on the other side. So I think what's happening here is this gist is causing the small bowel to basically move around, and that's why you're getting kind of this mesenteric swelling and it's moving in position basically. But the point is, you've got a cystic lesion coming off the small bowel, and it's now in the right iliac fossa on the MRI, whereas it was in the left side of the abdomen on the CT. Primary differential for a cystic lesion coming off the small bowel, you need to think GIST. In a patient with NF1, there is an association. It's a recognized association between GIST and NF1. Okay, so this is probably the most difficult case in the whole session today. So well done for giving that a try. And then I think we did this case, didn't we? So yeah, good. This is LIP. So you've got lower, the reason it's LIP is because it's lower zone predominant. Okay. So that makes it LIP, and it's quite regular uniform cysts. In LCH, you'd expect to see emphysema. You kept asking me for a smoking history, and I wasn't giving it to you because sometimes the examiners will just be like that. I mean, you can tell this patient doesn't have emphysema and they've not got any obvious airways disease to suggest they're a smoker. So you can say that, okay? You can say, I know there's no emphysema. I know there's no gross airways disease to suggest this patient is a smoker. Therefore, I think LCH is less likely. Also, why is this not LCH? What else do you see in LCH?
It's in the Costa-Frank angle, the cystic change.
Yeah, but also you see nodules with cavitation. So you see the way LCH works is you go from nodule, then it cavitates, and then it becomes a cyst. That's the progression of disease. You're not seeing, except that one solitary nodule, which looks suspicious, you're not seeing any kind of cavitating cystic nodules. And this is not LAM, lymphangioliomyomatosis. In lymphangioliomyomatosis, you see cysts everywhere, even at the apices, okay, they're just scattered everywhere. So that's not this. And then the other cystic lung disease to consider is Birt-Hogg-Dubé, very rare. Typically, yeah, exactly. You can look at the kidneys. You can then describe it as cigar-shaped cysts, kind of like cylindrical. But it's not the case here. So if you'd asked me, I would have told you that this patient has Sjogren's disease. So this is the actual case. The patient has Sjogren's disease. If you see a LIP case, you need to think, is there an autoimmune background like Sjogren's? Because there's an association. So you should ask the examiner, does the patient have Sjogren's disease? And then, yes, I think a few people said it in the chat, so that's well done. And then the other thing that LIP, there's a risk of transformation to lymphoma. So that's what I was trying to push you for. So like, what could this nodule be? What do we need to rule out? So we need to make sure that there's no lymphoma in this patient. And then there would have been a PET, which shows you that it's cold. Okay, so this is nothing, this is benign, this nodule. It's just a benign nodule. Sometimes in these patients, you can get like amyloid deposition, or it might be a granuloma or something. But as far as we can tell, this is a benign lung nodule. It's not taking up FDG, so it's not going to be anything related to kind of lymphoma here. And that was the end of that case. And then the other case was the pelvic radiograph. So yeah, very good. It's a left-sided Met. You got that it's a wide zone of transition. So if it's a narrow zone, you can normally trace around it, but here it's very blurred, isn't it? You can't really tell where the normal bone begins and where the Met begins. I would, just in terms of feedback, try and get to the diagnosis a bit quicker if you can. If you do see it, just say, okay, look, I know there's a lytic lesion with a wide zone of transition. This is concerning for a malignant bone lesion, and the patient needs a CT cap. So you said MRI hip, but the MRI hip, I don't think that's the next best thing to do. If you think it's a malignant lesion, you need a CT chest abdo-pelvis to find out where the malignancy is, right? So the obvious thing is there's hepatic metastases, multifocal hepatic metastases with this kind of pseudocirrhosis appearance. Then you can scroll through, you can see the lytic soft tissue lesion here. But the key thing here, and I kind of pushed you towards this is a gastric pull-up. So this is stomach. That's why it looks weird. This is normal stomach mucosa. It's not thickened or abnormally enhancing. This is just what the stomach looks like, right? It's the gastric rugae, and the patient has had an esophagectomy. So that should make you think they've had an esophagectomy. They've now got Mets. So this is recurrence. You have to say recurrence, okay? Because they obviously had the cancer chopped out. They presumably we can assume that it had been cured at some point. They had the cancer chopped out, and now they've presented with widespread metastatic disease. So that was that case. And then actually what I wanted you, we're a bit short of time, but there's this lesion here. Okay, it's pushing on the cord. You can see that?
Yes, yes.
Yeah, it's pushing on the cord. So the next thing you'd ask for is an MRI spine to check for cord compression. That was the only step that we missed there. But yeah, I won't go into that. There is no cord compression. But no, otherwise very good. And definitely picked up all of the findings, which is excellent. It's just that first case I think was really difficult. So don't worry about that one. But otherwise you did very well. Okay, good. Can we have candidate 3, please?
Good evening, sir.
Evening. Sorry, I was looking at the chat. Someone said, could it be amyloid? So when I'm referring to LIP case, yes, exactly. It can be amyloid. If it's a benign lung nodule in LIP, it can definitely be amyloid. Yeah, fine. That's all the questions. Okay. Good evening, candidate 3.
Yeah, hello, sir.
So candidate 3, if you ask for my screen.
Yeah, I requested.
Yeah. Okay, go for it. Your time starts now.
Okay. I'm presented with axial, CT, chest, and abdomen images of a patient. I would like to take a moment to scroll through the images. Then I would like to start commenting. So it's taking a little bit time. Should I?
Okay,
Is there any
just pause a
scroll
second.
bar?
Just 1 second. Stop scrolling.
Yeah. It's
Okay, now
taking
try.
quite time.
Try scrolling now, please. Yeah, so it should work. If you left, yeah. Okay, go for it.
It's working. So I can appreciate that there is bilateral pleural effusion and there is ascites, a cystic, exophytic. There is evidence of gallbladder distension. Stomach is distended with internal with internal air fluid level. There is evidence of mesenteric stranding. I would like to go till the last slide says. I can see a beer paw sign with the xanthogranulomatous appearance in the right kidney. There is an evidence of hazy attenuation seen within the abdominal wall on the right side. And as I extend down, I can see that this is an elderly patient. There is a soft tissue.
Just focus on the abdominal findings.
So there is a diffuse thickening of the bowel loops. Some of them are showing.
That's fine. Focus on the kidney for me.
Focus on the kidney. So I can appreciate that there is left kidney there is fatty replacement with a staghorn calculus, and there is adjacent parenchymal thickening. I'm trying to look for the right kidney, which I'm not able to appreciate. There are surgical slips seen in the bed of the kidney, and there are some attenuation within the soft tissues of the renal bed region. and there is the epicenter of the bowel thickening is also located within this area. I can see there's some air foci which I suspect can be extraluminal. So I would like to see it in the bone, in the
That's
lung
fine.
window
They're
images.
intraluminal. They're intraluminal. Just focus on the kidneys.
Okay, so
So what do you think's going on with the left
I
kidney?
would like to take a I would like to take a history of the I would like to take a history of any prior surgery
So what
for
surgery do
right
you think
kidney.
what surgery do you think they've had?
I think they've nephrectomy, but I
Okay.
would like to know for which reason was it done? Was it due to the same same reason, xanthogranulomatosis pyelonephritis, or was it due to some RCC? Also, I can appreciate that the kidneys is the left kidney is a bit ectopically located, and there is increased fat attenuation seen adjacent to it. There is a significant replacement of the
Okay. So
abdominal wall by the.
do you know
Hmm?
about the staging of xanthogranulomatous pyelonephritis?
No, I don't know about the staging, but in the end, there is a complete replacement, and I
Okay, fine.
can see
And
that
what's
there
the
is
management?
the management is excellent, but I can appreciate that there's only one kidney, so it has association with the Proteus and E. coli. So blood culture level need to be done. If the underlying organism is there's a high levels, I think that the patient can be treated with antibiotic, but ultimate there is a ultimate end result
So
is
what
a
do you
surgery.
so what do you think happened to the right kidney then?
I believe that the right kidney could have been a same, most likely there could have been a same process which has affected the right kidney first, and now it has started affecting the contralateral side as well. But I'm also concerned about the renal bed region. There's some bowel dilatation and thickening, and which could be post-inflammatory changes extending to the bowel. I will like to correlate with
And
the
this is
past
no, this
record.
is a post-operative scan. That's why it looks like that. So that's fine. Okay, we'll stop there. Move on to the next case.
Mhm.
Okay. Okay, please have a look at this pelvic radiograph. This is an elderly gentleman who presents with pelvic pain.
I'm presented with a radiograph pelvis frontal projection of an elderly gentleman who presented with pelvic pain. I can appreciate that a calculus, there's a hypodensity seen within the region of the lower pelvis with an adjacent soft tissue. There is evidence of erosion of the superior part of the pubic symphysis, and it has a kind of blunt margin. It has a kind of lucent appearance. I would like to, in my routine practice, change the window to make it a little more clear because there are overlying bowel shadows as well. As this is an elderly gentleman, I would also like to look for the rest of the bones, the rest of that particular area, the superior part, extreme superior part of the pubic symphysis on the right side is showing a lytic appearance. There's a calculus which is in the probably in the VGJ location, and I can appreciate a soft tissue adjacent to it. So I will be concerned about a prostate malignancy, about a bladder malignancy, or it can be any rhabdomyosarcoma. So I will advise with a CT chest abdomen pelvis with contrast for this patient. As this is an elderly and I don't want to miss any sinister pathology. Should I
Okay.
request control again?
No, you should have control.
Okay. I'm presented with axial contrast enhanced CT chest, abdomen, pelvis images of the same patient, in which I would like to take a moment to scroll through the images.
Yeah, just stop scrolling for a second. Sorry, just stop for a
Okay,
second. Sorry, it's
excellent.
let's give it a second to load. Sorry, just
Mhm.
my internet's a little bit slow. Okay, go for it. It's mostly loaded now.
Okay, thank you. So I can appreciate that this is a parenchymal, this is a contrast enhanced study, and this is mediastinal window. There are multiple lymph nodes are seen in the subcarinal and bilateral hilar region. Multiple metastases are seen within the both lung parenchyma without any zonal predilection. They are, as I'm going towards the basis, they are becoming more large in size. I'm trying to look for the liver. The liver do not have any soft tissue dense lesion. The adrenals, I would also like to look for the region of adrenals. And there is the left adrenal is a little bit bulky. I'm trying to look for the kidneys. There is differential attenuation, there is differential enhancement. The right kidney is a bit enlarged and it is having a reduced enhancement. Also, I can appreciate that there is a filling defect seen within the pelvic ileal system in it, and there is. I would like to trace it further. It is not being traced, so I suspect that this can be due to any transitional cell carcinoma, as the patient is elderly and it is in a typical location of pelvic ileal system. I would like to trace it further to look for any other lesion. I'm also trying simultaneously look for any mesenteric or nodal or para-iliac lymph nodes or masses. So I would like to extend it down in the, I also saw there is a, it is a male patient. No, 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 no. So this is a lady and there is a dermoid also. And there's a dermoid also, and the bladder is not filled. And the pubic symphysis region, I can appreciate that there is a lytic lesion with adjacent soft tissue mass. The pelvic region is otherwise unremarkable. I would
So
like
what
to
do you
go
think's
till the
going on?
last. I think that there is TCC with multiple metastases in the lung. I would like to look in the sagittal bone window images to see the spine, underlying status of the spine. I would also like to see the both pulmonary arteries once again closely to rule out any embolus. And
Okay, fine. So all of that's normal. What would you like to do next?
I would like to refer the patient to the relevant MDT, urology MDT, and to put a drain for the urgent. No, there was no obstruction. So I will advise a histopathology correlation. Their MDT should be discussed, and there should be what treatment? Patient should be put on treatment.
Okay, that's fine. Thank you. Okay, so sorry, I'll have control, but yeah, go for it. This is a 30-year-old with ankle pain.
Okay, this is the ankle mortise view, left side of a mature lady, mature skeleton patient. I can appreciate that there is a well-defined eccentric lesion seen in the cortex, and it has a location which is very typical of fibrous cortical dysplasia. I would like to compare the prior record for this. And I can appreciate that in the medial talar region, there is a lucency which is seen extending into the adjacent bone. There is no evidence of break in the continuity of the bone, and the soft tissue is normal. Rest of the bones are normal. I would like to see it in any other view, any orthogonal view, if available. These are the orthogonal view of the same patient, and I'm not able to appreciate apart from some osteopenia. And there is again a sclerotic lesion seen. I believe that this is the same fibrous cortical defect which I saw in that one. But as the patient presented with ankle pain and I saw lucency in the medial malleolar region, I will be concerned for a stress fracture and insufficiency fracture underlying bone is diffusely
Show me where are you
osteopenic. So
seeing the lucency? Where are you seeing the lucency?
Can you see the cursor?
Say that again.
Here.
Oh, I can't see
And
you.
can you see it now?
Okay, I'll tell you that's normal. So how would you confirm what this lesion is?
This one?
Mm-hmm.
I will confirm it with the prior record if available, and I
Okay,
will
that's
advise
fine.
MRI. Yes, the patient is presenting with pain.
So this is a radiograph from when the patient was younger. So does that help you?
Yeah, this is a lucent lesion which is located in the same particular location, and at some time prior it was lucent, but now it is a little bit more sclerotic, but the features are quite benign because it has a very well defined zone of transition. It is
And what do you
eccentric.
think?
There is
What
no
do you think the
evidence.
lesion is?
I think the lesion is a fibrous cortical defect.
Okay. And on this radiograph, the one that I showed you, roughly how old do you think the patient is?
Roughly how old? It's an adult with a I think it's a middle aged, like 30s.
Okay. And what do you know about the time course of non-ossifying fibromas? What happens to them over time?
Over time, they blend with the cortex and they become more sclerotic and they try to fade away.
Okay. Thank you. Okay, 1 second. This patient presents with knee swelling and not unable to weight bear.
This is the frontal knee radiograph, left side of a mature skeleton. Patient is a lady and is unable to bear weight. I can appreciate that there is a diffuse soft tissue swelling, particularly along the medial aspect of the knee joint. There is evidence of a break in the continuity along the fibula, the uppermost part of the fibula. There is a significant osteopenia. I cannot appreciate any other area of sclerosis. In my routine practice, I would like to zoom it and I would like to simultaneously compare any orthogonal view and this view to compare the lesion. So this is a lateral view, and can you a little bit zoom it? So there is an expansion. There is an expansion of the fibular cortex with a certain periosteal reaction and a break in the continuity along the cortex, along the, if you can see my
I'll tell
cursor,
you
along
the
the
fibula
posterior
is
margin.
normal.
Fibula is normal. Then there is a diffuse soft tissue swelling and edema around the knee joint, and there is a prominent osteophyte seen along the undersurface of the patella. And I'm as the patient has presented with knee pain and there's a diffuse soft tissue swelling, so I would like to see it in. I will advise an MRI
Okay,
for
that's
this
fine. So
patient.
what happens is actually the patient goes away, and this radiograph is called normal, and the patient comes back in a couple of comes back in about a week or so, and sorry, they have another knee radiograph in A&E. Okay, so if I just show you the lateral.
Okay, so in this lateral, I can appreciate that there is a sclerosis seen along the tibial superior part of the tibia. Posteriorly, the bony margins are fuzzy and a bit blurred, and there is a bit of there is a periosteal reaction along the posterior surface of the tibia,
Show
and
that to me, sorry.
there.
Show me the periosteal reaction.
This one here. These
Okay,
area are this is
yeah. So just where do you think the abnormality is on this scan? Show me. Sorry.
in this scan, it is in the tibial plateau,
Just
posterior part along
show me with the cursor.
this one.
No, okay, that's just projectional. Is there anything else that's going on here?
Yeah, here. So I can appreciate that there is a break in the continuity along the anterior surface of the tibia with an adjacent soft tissue, and there's a moth-eaten type of appearance, and there is a periosteal reaction. And
Okay, so what would you like to do next?
I will definitely like to do an MRI with contrast and including whole of the tibia and partly
At this
femur
point,
as well.
what's your differential diagnosis at this point?
My differential diagnosis is that this is likely an aggressive lesion. It can be a subperiosteal abscess, it can be a metastasis, or it can be a myeloma. Myeloma is more likely to be central, and this is not the typical location. Met can be a differential, but
So what
that
do you
is
think? As you said, this is quite eccentrically based. So what else do you think this could be?
an aggressive form of osteomyelitis, but any osteomyelitis can be a possibility if the patient has history of trauma, any
Okay, that's fine.
piercing
Don't worry.
injury.
We'll have the MRI new. So don't scroll yet. What sequence would you like?
T1 first, T1 session.
Okay, you can scroll.
So these are the T1 MR images of the patient in which I can appreciate that there is a significant area of abnormal marrow signals seen within the anterior part of they are involving the metadiaphyseal region. I can see that there is there's an hypointensity seen within the adjacent part
That's fine.
as well.
Ignore that. Ignore that. That's just a benign bone lesion.
I would like to see, there is a hypointensity which is seen of the same signals along the lower part of the femur as well. And so I would like to see it once again. I would like to see it in the PD FET set. There is a some similar kind of signals were also being seen in the lower part of the femur. So yeah, as I mentioned, there are diffuse altered marrow signals, but the anterior surface of the tibia is showing hyperintensity with some break in the cortex, and there is more profound changes seen. I would like to see it in the, if available, T1 FET set contrast enhanced images.
Okay, but
Again,
what else is abnormal on this image?
What's the abnormality? There is a joint effusion, and there is a significant thickening of the patellar ligament with an undulating margin, and it is exact the site of attachment of the patellar tendon. There is a possibility that secondarily, due to this lesion, there is a part rupture of the tendon.
So what do you think of the patellar tendon?
What I think of the patellar tendon? Patellar tendon is hyperintense and has it is altered. It can be an infection which is tracking along with, or I would like to take a history of trauma. It can be a secondary bursitis, or it can be tendinopathy. I would like to take a history if the patient is a known disease of rheumatoid arthritis or has been a victim of trauma at this
I'll show you the post. Stop scrolling for a second. I'll show you the post contrast because you asked for that, didn't you? Yeah. Okay. This is the post contrast.
So these are the post contrast images, and I can appreciate that along the there was a joint effusion, and along the effusion there is enhancement. So it is definitely an infective collection, and it is there is a prominent tibial tuberosity, and secondarily there is involvement of the tendon.
Okay, so summarize. What do you think is going on here?
I think that there is a abscess, periarticular abscess or a septic arthritis with patellar tendon involvement. I would urgently like to advise a blood culture level, and there should be an urgent ultrasound correlation, and if possible, it should be drained. And Yeah, and refer the patient to, I will flag the finding to the.
What should be drained? Show me what should be drained.
This collection here in the patellofemoral compartment. This is enhancing. I don't
Okay,
think it is. Yeah, there is a diffuse enhancement. It is continuing superiorly as well. If possible to drain, otherwise it can be treated with antibiotic. And there is another, yeah, it is the most enhancing here. So I believe that this is the most dependent portion and it is possible to drain here.
okay. And is there anything else you think this could be?
And it can be rheumatoid. Rheumatoid collections can, secondary effusions to rheumatoid arthritis can sometimes show enhancement. That's why I advise a blood culture level. And there is fluid tracking along the muscles as well. Underlying bone is showing subtle abnormal signal, which I previously mentioned. The vessels
So
are not
what do you think
returning
about the
normal.
bone?
About the
What do you think about the anterior tibia on this study, on this sequence?
anterior tibia, there is. I would like to know if the patient has any prior X-rays or if there was a.
Okay, good. Let's stop there.
Is it an
So we're just reaching time. We'll go through it. Don't worry. So if you stop scrolling for me, thank you. Well, very well done. This was also a very tricky case, to be fair. So, let's start from the top. How do you feel that went?
I don't feel good.
Yeah, as I said, no one ever feels good after this, but you did very well. Honestly, it was really, really good. You Let's just go to the first case. I mean, you picked this case straight away. I was almost a bit disappointed that I put the case was almost, I felt like too easy for you because you got it straight away. So you just you straight away saw that you had xanthogranulomatous pyelonephritis, which is what this case is. So it's one of those things, if you've seen it before, it's quite textbook, isn't it? So very well done. You got it straight away. So what's happened here? This is a post-operative scan. Just in terms of your general technique, I would say you you tell me you're going to scroll through and have a look, but then as soon as you start scrolling, you start talking. And this is what you said something along the lines of I would like to take a second to scroll. And then as soon as you start scrolling, you're saying there's mesenteric stranding, there's air fluid level in the stomach. Then you would tell me literally everything you see in real time. And then at one point, I think you told me there's like a dermoid. I can't remember if it was for this patient or another patient, but I think it was for the other patient. My point is, don't do that because I want you to focus on the main finding. And a lot of the times you may say things which aren't relevant. So that, it's coming on an air fluid level in the stomach. That's a normal finding, right? So only mention things which are relevant. Fair enough, mesenteric stranding and subcutaneous edema, that is relevant because obviously that's not normal. But like things like a dermoid or an air fluid level in the stomach, I wouldn't mention these things because that's just a normal finding. In this case, and I told you to focus on the kidneys. So I just want you to tell me there's staghorn calculus number one. There's multiloculated dilated calyces. This is in keeping with xanthogranulomatous pyelonephritis. There's been a right-sided nephrectomy. And you could say, there's lots of mesenteric stranding and there's reactive nodes. So this could be an immediate post-op scan. So this is a post-op scan. They've got all of this subcutaneous edema. So this is just a post-operative finding. But to be honest, you nailed this case. You got it straight away. It is xanthogranulomatous pyelonephritis. So very well done. Just try not to get carried away by other things. Like, again, stuff down here. Try and focus on the main findings. But the examiner will guide you in the exam anyway. So don't worry too much about that. Do you have any questions on this case?
So you said that what's the final treatment? So if the final treatment is surgery, what so far I've read. So if we do surgery for both sides.
Yeah, so the treatment is nephrectomy. Obviously, bilateral, I'm not is a different case, and that's quite rare. So that will require MDT management. So whenever you get onto something like that, you're not expected to treat the patient. You're not a urologist, but you're expected to know what to do with the imaging and how to follow it up, right? So in this case, you'll be like, the patient has had a right-sided nephrectomy. I suspect this could have been for a prior xanthogranulomatous pyelonephritis. They now have a left-sided xanthogranulomatous pyelonephritis. This requires an MDT discussion to decide on next steps for management and whether a further nephrectomy would be prudent. because I don't know if I honestly don't know if they would take out the second kidney or not, right? That's a very complex case. Good. So no, but very well done. You got it straight away. Again, to be honest, you got this case straight away. I think you get distracted sometimes. Is the only thing I would say. You're telling me about a fracture. This is a normal ankle radiograph, right? So there's no fracture. This is an eccentrically based. Whenever you see a bone lesion, you need to tell me, is it benign or malignant? And you did tell me. So, and the key thing I want to know, what is the so this is for the chat as well. What is the most important thing you're looking for in a bone lesion to tell you if it's malignant or benign? There's one, and what's the most sensitive thing? Yeah, zone of transition. So this is a narrow zone of transition. I can get my pencil and I can trace around it. That's what zone of transition means. What does the margin look like between the lesion and the bone? It's thin and it's well defined. This is a benign bone lesion. And it's a non-ossifying fibroma. Okay, I think fibrous cortical defect might be the old term. I mean, I'm not an MSK radiologist, but my understanding that's the old term. And non-ossifying fibroma is what we say now. I think classically they said a fibrous cortical defect was if it's small and a non-ossifying fibroma is if it's big. But I think we just say non-ossifying fibroma now, but you can double check that. And the key thing is they start off as lucent when the patient is young, and then by the time they're about 30, they become sclerotic and disappear. So when I asked you, how old do you think this patient is? Absolutely, this patient is probably in their 30s and this thing is starting to disappear. It's a benign bone lesion. Someone said osteoid osteoma. So osteoid osteoma is cortically based and they have a lucent center. So this is less typical of that. Yeah. Exactly. It's a non-touch lesion, as someone has said in the chat. It's benign, leave it alone. It will go away. But very good. I think you did very well in that case. What else did I show you? Oh, yeah. So I think this is actually quite a difficult spot on the X-ray, to be honest. Like when I first saw this X-ray, I was trying to think, is it abnormal or not? The one thing I would say is always ask for another view. I mean, you did get it. It's this thing here. And this can be tricky because you have bowel, but like if you look at the other view, you can see it's very blurred and you shouldn't, the bone should not look like that. You've lost the superior margin on both the AP and the turned view, yeah? So you shouldn't see this on both views. So this is definitely suspicious. Like when I see that view, that's 100% suspicious to me. When I see this view, this is suspicious, but you can be confused because there's bowel there. But to be honest, you've definitely lost the superior border. I think you did very well to pick that up. And the thing I really liked here is you told me, so a lot of people would say this is renal, this is renal malignancy, or they might even say RCC. This is not RCC. This is very definitely TCC because it's centered on the renal pelvis, right? So, I mean, there's all these lung lesions, which you can also mention, and that's important. I think you might have done that. But yeah, so this is centered on the collecting system. So this is very definitely, RCC is a parenchymal lesion and it's a different pathology and it's going to be managed differently. This is a TCC, which is a collecting system malignancy. You can see it in the renal pelvis and the ureters or in the bladder. It's the most common bladder type of cancer. It's less common in the kidneys, but you do see it. And yeah, that's what this is. So well done on picking that up. The only thing I would say is you described it as a filling defect. That's my only criticism. You can't describe it as a filling defect if it's not a urographic phase. So, but it's just, I would just say there's a soft tissue attenuation within the, the calyces and renal pelvis. And also, yeah, this was the case you told me there's a dermoid. So there might be somewhere. Are you talking about the calcium? I mean, yeah, I wouldn't mention stuff like that because it's not relevant to this thing here. It's not really relevant to the case. And that's so don't get distracted. That's my feedback. And then finally, this is a challenging case. So I showed you this radiograph first. And you can see this is not normal. So it's subtle, but you've lost, it's concave. The tibial tuberosity shouldn't normally look like this, but it's subtle. And then on the follow-up radiograph, it's very obvious, isn't it? that this is eroded and destroyed. So the differential here would be yes, malignancy, but typically malignancy, you can get it definitely eccentrically, but it's often, more kind of centrally based. The other thing is, you said this is a moth-eaten appearance. This is not moth-eaten. This is normal bone. This is abnormal, but all of this stuff's not moth-eaten, okay? The differential here would be infection versus malignancy. And then when you look at this, so I asked you which sequence. You said T to T1, which is perfectly fine. I would start with a T1 as well. There's a bit of heterogeneous marrow signal, particularly where the actual pathology is at the anterior tibia. Then I would look at the PD fat cell, which is exactly what you did, which is perfect. Again, you can see the heterogeneous marrow signal, and you can see there's particularly high signal, intense change there, the anterior tibia, which is all eroded, as we saw on the radiograph. There's diffuse thickening and high signal within the patellar tendon. This is extremely abnormal. The patellar tendon should normally look like this. Can you see that?
Yeah, I can.
Yeah, candidate 3. So that's what the tendon should look like. But look at it; it's expanded with fluid, and it was all enhancing as you saw. So there's a thickened patellar tendon with enhancement and destruction of the actual the insertion site. So the differential here is infection. There is another differential which is actually reported as more likely. There is another pathology which can cause this appearance. Do we have any thoughts in the chat? So, I mean, and just going back to you, candidate 3. So this is actually a normal, it's not like a significant neofusion. So when you look at NEMR, you often do get a little bit of fluid. I mean, then maybe there is a bit, there is a bit more than usual, but it's not like a massive effusion. Yeah, so someone said it in the chat. So this could be gout. Gout can sometimes cause tendon infiltration and bone destruction like this. And actually, that's what they initially thought this was. So they aspirated the joint and it was negative. And they didn't see any crystals either, to be fair. But radiologically, what can you do? If you think this is gout, what next imaging can you do?
There's a CT. There's a CT
Specifically?
for, I forgot the name now, but there's a CT for this, specifically for gout.
Yeah, dual energy CT. So dual energy CT will show you evidence of urate deposition. And they did a dual energy CT and it was negative. So this is a mystery case. It's a differential case, and the differential is infection. I think infection has to be number one. I don't think I would look at that and think that's gout. The person who reported it actually said this is more likely gout. I mean, I would say that's more likely infection, and then you can think about other things like gout. But the point is, this case makes you think. You came up with a reasonable differential. You said infection and malignancy off of the radiograph, and then you said infection off of the MRI. So I think that's perfectly fine. And this is feedback to all of you, and I forgot to say this earlier, but in the 2B, you're judged on each image. So you'll get scored for the knee radiograph, and then you'll get scored for the MRI. So make sure you give a differential for when you're just looking at the initial image. Okay, don't just say there's bone erosion, I'd like to do an MRI. So there's a bone erosion. This could be infection, this could be malignancy, this is suspicious and it needs follow-up. I would like to do an MRI. Good. Okay, so can we have, very well done, candidate 3, though. That was really good. Can we have candidate 4, please?
Yes, I'm here.
Okay, hello, candidate 4. Welcome. You're the final, last but not least. Hopefully you're still with us. What is this? Okay, good. So this is a chest radiograph. This is someone presenting with abdominal pain.
Okay. I have been presented with X-ray chest frontal projection of a skeletally mature patient who presented with abdominal pain. I can appreciate that the cardiac size appears to be mildly enlarged. There are prominent hyla bilaterally. There is haziness of the left lower zone and left costophrenic angle. There is suggestive of left-sided mild pleural effusion. Mild haziness also noted at the right costophrenic angle. Otherwise, I cannot see any pulmonary nodules. The trachea is central. There is mild aortic arch calcification. The soft tissues appear unremarkable. I'm looking at the bones. The visualized bones appear normal. And this patient presented with abdominal pain. I cannot see in the visualized upper abdomen, I cannot see any evidence of free intraperitoneal air. No calcification foci noted.
Okay,
So,
that's fine. So they actually go on to have a CT abdomen and pelvis, so you can have a look at this. If you take control of my screen, please.
okay. I will request control.
Yeah, please do.
Okay. So this is the CT scan abdomen, axial sections, post-contrast images in the portal venous phase. I will scroll from top to bottom. Um, uh, here, okay. I can appreciate that there is well-defined a lesion or noted just adjacent to the stomach. I'm trying to trace its
Sorry,
epicenter
where do
or
you see
origin.
where do you see the lesion?
One second. So this is the pancreas, and just above the pancreas and adjacent to the stomach, I see this area. Just above the left kidney.
Oh, okay, fine. So that's I'll tell you that's splenic tissue.
This okay, because it's not at its normal position. Okay, right.
Yeah.
Scrolling down.
Just focus on the upper abdomen, please.
Okay. I'm scrolling back up. Okay, now I am looking at the upper abdomen. I can see that the liver is normal in texture and the gallbladder is normal. I'm looking at the stomach because okay. I feel that there is herniation of the stomach and the left thoracic region. I would like to
going on.
see the coronal image to see any.
Okay, you can look at the coronal image. So I'll do it for you. Don't touch anything.
Okay.
Okay, I'll scroll through this one for you.
Okay. Thank you.
For the purpose of time.
Yes, I can appreciate that there is some maybe defect noted in the left hemidiaphragm, and there is a herniation of stomach through the defect into the lower part of the thoracic cavity. Otherwise, the gastric wall is not thickened.
You can scroll.
This is axial again. Okay.
So tell me, what do you think the diagnosis is?
Is there any history? I would like to take any history of trauma.
There's no history of trauma.
Okay. So the other possibility can be the stomach is also dilated, and there is also air fluid level noted in the stomach. Um, uh, uh, can
So
I
what do you
see
think
the
the diagnosis?
coronal? Can I see the coronal again? I want to rule out any twisting of the mesentery.
Okay, have a look at the coronal.
Okay. Yes, the stomach is extending into the thoracic cavity. I feel that there is a defect in the left hemidiaphragm, and again,
Okay,
this
so
is
what do you
just
think the
jumping.
diagnosis is?
I feel that this is a case of gastric volvulus, because I feel that the cardia, or the a part of the stomach is the stomach appears to be twisted. It's on the upper side.
Okay, so what type of gastric volvulus do you think this is?
This appears to be 1 second. Can I scroll?
Yeah.
This appears to be mesenteroaxial.
Why do you say that?
Because in the mesenteroaxial, the lower part of the stomach, that is the pylorus and the antrum, it is seen above the cardia. Here I can see that it is okay, 1 second. This is the gastric fundus. Okay, I will see it again. Sorry, the scroll is actually.
Okay, you just tell me, which one do you think it is?
I'm thinking of some diaphragmatic rupture with extension of stomach into the thoracic cavity with
Just tell me, which type of gastric volvulus do you think this is?
ex- uh, first it looked to me like mesenteroaxial,
Okay,
but
that's fine. I'll take control of the scrolling. Thank you.
okay, thank you.
Okay, here's a chest radiograph. This is someone who presents with acute shortness of breath.
All right. I have been presented with X-ray chest frontal projection of a skeletally mature patient, in which I can appreciate that there are prominent reticulonodular markings that are seen in the lung parenchyma bilaterally, predominantly in the lower zones. I can see a small lucency noted in the right lower lung zone. Otherwise, there is no evidence of pleural effusion. The cardiac size appears to be borderline. Uh, the the bones appear normal. I cannot appreciate any other prominent lung nodules other than just that small lucency noted that is seen in the right lower lung zone. And the trachea and the bronchi appear normal. There is mild haziness noted in the right perihilar region. And yes, and the ribs and the
What's
other
what's the key
realized
finding? What's the key finding here?
key finding is the prominent reticulonodular markings or reticular markings in bilateral lower zones, as
Okay,
well
so
as a small lucency in the right lower lung zone.
what's your differential here?
Based on these findings, I would like to check the history of the patient. But the lung volumes are preserved. Lung volumes are preserved. There is no loss of lung volumes. The cardiac size is normal. So
What's your differential?
differentials could be pulmonary edema, or other possibility can be some interstitial lung disease with preserved lung volumes. Um,
And what would you like
yes.
to do next?
Sorry,
What would you like to do next?
CT scan chest.
Okay. Just 1 second, let it load.
Okay.
Okay, try scrolling now.
Okay. So I've been presented with a CT scan chest axial sections in the lung window image. I can appreciate that there are multiple bilateral widespread areas of ground glass opacification that are seen um, uh, in the lung parenchyma bilaterally. These are seen in the upper lobes in bilateral perihilar regions as with some of confluent areas of airspace opacification as well. And going down, there is changes, mildly, no significant bronchiectatic changes noted, but there is mild peribronchial thickening noted bilaterally. Atelectatic changes noted in the lingular segment. And this ground glass opacification, few areas also noted in the right lower lung zone. Along with the ground glass opacification, there is some intralobular as well as interlobular septal thickening also noted that is seen predominantly in the middle lobe as well as in the lingular segment and also in the upper lobes. So the cardiac size does not appear to be enlarged. There are no prominent, no significant. I would like to comment on the lymph nodes in the mediastinal window image. So based on these findings, this appearance is giving the appearance of a crazy paving, which is normally mostly seen in pulmonary alveolar proteinosis. There is no evidence of pleural effusion on either side. I would
Okay,
like
is there
to
any other
compare with
differential?
differential can be pulmonary edema, pulmonary hemorrhage, and if the patient is immunocompromised, there can be a possibility of pulmonary pneumocystis carinii pneumonia.
Okay,
I would
how,
like
how
to
would you
take the
how would you describe the ground glass?
ground glass.
How would you
This
describe it in its
patchy
location?
uh, ground like these are patchy areas of ground glass opacification. Some are dense and
Okay,
there is along with the interlobular septal thickening.
okay, that's fine. Thank you. We'll move on to the next case. Okay, have a look at this chest radiograph, please.
Okay, this is an X-ray chest frontal projection of a skeletally mature patient in which I can appreciate that there are prominent hilar shadows bilaterally, as well as prominent interstitial markings in the lung parenchyma bilaterally, predominantly in perihilar regions and more prominently seen on the right side. I can see that there is slight haziness noted at the right paratracheal stripe, right paratracheal region. Otherwise, the lung volumes are preserved. There is no evidence of any pleural effusion on either side. The cardiac size is normal, and the bones appear unremarkable. Here on this chest X-ray, my differential diagnosis is sarcoidosis. Other possibilities can be tuberculosis or lymphoma. I would like to take the history of the patient and compare with any previous X-ray if available. And I would like to further suggest a CT scan of the patient for further evaluation.
Okay, let's have a look at the CT scan. So you can scroll.
It's the same patient?
Same patient, yeah.
Okay, I will scroll. So I have been presented with the CT scan chest, axial sections, lung window images. Sorry, it's a bit jumping.
No problem.
Okay,
Take it.
okay. Okay, here I can appreciate that there is mild septal thickening as well as there is evidence of bilateral tree-in-bud opacification noted that is seen predominantly in the upper lobes. Uh, the lower lobes of both lungs grossly appear unremarkable with no evidence of ground glass opacification, tree-in-bud nodularity, or
You can
pleural
scroll a
effusion
bit
on either
quicker.
side. I
You
will
should be
go
able to,
back actually.
yeah.
Okay, I will
It
go
should be
back.
loaded now, so you should be able to scroll properly.
Okay, I'm trying. Yes. I will go back to the site of abnormality. There is bilateral peribronchial thickening noted. Yes, there is evidence of ground glass opacification. Sorry, not ground, trine bud opacification, trine bud nodularity that is seen in the peribronchial as well as peribronchial location as well as peripherally, and is seen more prominently in the upper lobes bilaterally. This looks like an endobronchial spread of infection. And seeing the trine bud opacification, I would also like to see the other soft tissue window image to look for the lymph nodes, because I saw the prominent hyla on the X-ray.
So I'll scroll through this one for you. So
Okay,
please stop
thank you.
scrolling.
Thank you.
That's okay.
Okay, so okay, no significant axillary lymph nodes. There are few prominent. I could see the mediastinal lymph nodes, few prominent mediastinal lymph nodes, and there are lymph nodes in the pretracheal, paratracheal region, as well as in both in the hilar regions bilaterally. And these lymph nodes appear to be of low density. So with low density lymph nodes and trine bud opacification, here my first differential will be tuberculosis and also the upper zone distribution.
Okay, so let me show you another CT. Let me show you another CT that they had. They had a CT after this as well, a period after. So I'll show you. I'll scroll through this one and let me know if this confirms or changes your diagnosis.
Right. So this trine bud opacification has actually increased as compared to the previous CT. So this shows some progression of the pathology. Okay.
Would you describe this as definitely trine bud?
This one second. There is ground glass as well as trine bud, and there are some confluent areas of airspace opacification as well that can be seen now.
In terms of the pattern of nodularity, how would you describe that?
Pattern of nodularity, like centrilobular ground glass nodules.
Okay. And what do you think about the fissures?
And the fissures, there is some nodularity along the fissures as well. So in peribronchovascular and fissural distribution, there is more possibility of sarcoidosis.
Okay, so if you think this is sarcoid, what tests could you do to help make that diagnosis?
Yes, sure. I will advise the angiotensin converting enzyme levels. Yes, and I will refer the case to the pulmonary MDT for further management and also the follow-up.
Okay, good. I think that was good. Let's stop there. We'll go through those cases, okay?
Right.
How did you find that?
I think you can tell better.
No, so how did you find it? It's always good.
It was just okay.
Well, I think, as I said, I've always said you always think you've done worse, but you did very well. You picked up all the main diagnosis. This is gastric volvulus, so well done. I think when you look at this, you're scrolling through it, and you're like, it's actually quite hard to pick up. So you initially thought this was abnormal, right? And it is abnormal. It's the spleen, but it's in the wrong position. So the spleen, yeah. So we'll come on to that. So basically, this is gastric volvulus. If you follow the stomach, so this is the GOJ here, right? This is GOJ.
Right.
So don't overcomplicate these things. It's actually very simple. So GOJ is here. So normally the antrum of the stomach should be below the GOJ. But if you follow this, so the stomach comes around here, and then you can't follow it anymore. As you rightly said, it's flipped up on itself. So the antrum is actually here. So this is the stomach antrum here, isn't it? The pylorus and the stomach antrum is here. So it's above the GOJ, which is here. And you can probably see that in coronal if you prefer. Some people like to look at this in coronal, that's fine. So GOJ here, yeah.
Correct.
pylorus and antrum here. So it's above the GOJ. So that means this is a mesenteroaxial volvulus because the antrum has flipped above the GOJ. There's two types of gastric volvulus. One is mesenteroaxial and one is organoaxial. The way to remember it is O for organoaxial, O for obstruction. So that's the bad one. Mesenteroaxial, M for mesenteroaxial, M for mild. So that's the less bad one. Okay, that's how I remember it. And organoaxial, I think, is typically seen in older patients. Mesenteroaxial is seen in younger patients. And there's an association with eventration of the diaphragm. So that's what this, I wouldn't say this is a diaphragmatic rupture. I think it's just eventration. It's probably like a long-standing thing that they've had. And as part of this, the spleen is also abnormally positioned. So these are just associations that you can get with the gastric volvulus. You can get the eventration of the hemidiaphragm. You can get the spleen in an abnormal position. But the key finding here is this is mesenteroaxial gastric volvulus, and it needs a referral to the general surgeons. The other things to comment on, although this is not the one that's typically associated with ischemia, it's still important to comment there's no gastric pneumatosis, the wall enhances normally, there's no perforation. So always say those relevant findings.
Right.
Okay. Do you have any questions?
No, thank you.
This next case was a bit tricky, and it's a differential case. So I don't think you think there's one diagnosis. The key finding here on the chest radiograph is there's this bilateral lower zone perihilar ground glass, or you can call it haziness, or even like reticulonodular shadowing, right? So it's all lower zone distribution. The rest of the radiograph is normal. So when I ask you what to do next, personally in this case, so I'll give a differential. Like this could be infection, or this could be pulmonary edema, although it would be slightly atypical given the lack of pleural effusions. I would advise the team to treat the patient accordingly and do a repeat chest radiograph. That's what I would advise in real life. And that's what you should say in the exam. And then the examiner will be like, okay, we've got a follow-up CT instead. And then 33. So I think in terms of your characterization of things on, why is this normal? Maybe it's this one. Okay, so I would say these are centrilobular ground glass nodules, okay?
Okay.
And the way you know it's centrilobular is, the easiest way is you can see this subpleural sparing. Yeah.
Yes, yes. And this I do.
So no, so yeah, you do see subpleural sparing in NSIP, but that's this in subpleural ground glass nodularity of any cause, you'll get subpleural sparing. Okay, so this is centrilobular. This is the way I would describe it. There's diffuse centrilobular ground glass nodularity with a lower zone predominance, admixed with interlobular septal thickening, as you rightly said, with a few areas of more confluent consolidation. Importantly, there is no pleural effusion, because this could be edema, but there's no pleural effusion, which would be strange, right? If you expect this much lung change, but no pleural effusion and a normal heart size, then it's less likely to be pleural effusion. So this is a differential case. And the differential diagnosis here is if the patient was immunocompromised, I would suspect this could be PCP. Other causes could be pulmonary hemorrhage if there is a history of hemoptysis, or alternatively, this could be acute hypersensitivity pneumonitis. So those are your three differentials for this case. So in this instance, this is acute. This patient was diagnosed with acute hypersensitivity pneumonitis. I don't think you can definitely say that just on the imaging alone. Obviously, you need the history. But this is going to look like, those are your three differentials: PCP, pulmonary hemorrhage. Pulmonary hemorrhage, you tend to get a bit more fluffy consolidation, which you're not seeing here. And then hypersensitivity pneumonitis. I think, alveolar proteinosis, but you tend to get a lot more interlobular septal thickening. So it all looks crazy paved. But, you're just seeing a few elements of crazy paving. So I wouldn't go down that route. And alveolar proteinosis is extremely rare. I've never seen it except in kind of case presentations and things. Some people have said a few other differentials. So AIP looks like acute respiratory distress syndrome. They're both the same thing, which is also the same thing as non-cardiogenic pulmonary edema. But you tend to get, in those cases, you tend to get dependent consolidation, which then has a gradient, which becomes less and less dense and becomes ground glass. So it doesn't quite look like this. But yeah, I mean, it's a potential differential. I would just go with things which are more common in this case. Do you have any questions?
No, thank you.
And the last case, you did very well on. So bihilar lymphadenopathy on the chest X-ray, if it loads. So there's bihilar lymphadenopathy, more prominent on the right. There's perhaps some mid-zone airspace opacification on the right as well. Anytime you see bihilar lymphadenopathy, that needs to trigger in your mind sarcoid, TB, lymphoma. And you said all of those three things, which was great. So this is sarcoid, TB, lymphoma. I would like to correlate this with the patient's blood results and history, and I'd like to get follow-up cross-sectional imaging. So then I showed you an initial CT. So initially, this looks a bit non-specific, and I think it's fair to say that this could be TB. So on the first, is this the first? No, this is the second CT, sorry. Opened up so many. Case 35. So on the initial CT, it does look a bit non-specific, and it does look a bit like tree and bud nodularity. You could argue that it's perilymphatic. So if you look here, it's kind of like going around the lobule, and it's the subpleural nodularity. But I think in this case, to say this could be TB is reasonable, and it's non-specific. But I think on the next CT, this is looking more like sarcoid now. Okay, there's definite areas of kind of periphyseal, definite subpleural, nodularity, and it's looking more perilymphatic in distribution. So you can see, you kind of like, if you Google after this, you can look at the secondary pulmonary nodule, and it's like it's kind of like a polygonal shape. So you can kind of trace the nodules around the edge of that polygon, and that's what perilymphatic is. It's when the nodules are along the edges of the lobule. So if you take this here, there's like you can see nodule, 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 and you can also almost imagine that this is a lobule here. And then, similarly here, you can imagine that there's a polygon here, and then the nodules are all around the edge. It takes a bit of getting your eye in, but I would say that this is more of a perilymphatic distribution. There may be definitely some tree and bud nodules in there as well. But given the periphyseal stuff as well, yeah, I think you have to say this is most likely sarcoid. And this is a upper mid-zone distribution, which again is typical of sarcoid, isn't it? And I think you said on the X-ray, you said something really good. You said there's no signs of volume loss. That's really good, because you're telling me I don't think this is an established fibrotic lung disease. So those are important negatives. When you're looking at the CT, there's no evidence of volume loss. There's no evidence of bronchiectasis. The pulmonary trunk is normal in diameter. There's no evidence of a lung malignancy. Just get in the habit of saying those negatives. And as you rightly said, I'd correlate this with the patient's ACE and calcium, and they'll need a respiratory review. But no, really well done. Do you have any questions?
No, thank you. Thank you so much.
Okay, good. I think that wraps up everyone. Really sorry that we overran by half an hour. I hope that was of use. And I know I said we'd revisit the optic neuritis case. I think we've overrun, but what I would say is just go look it up, STIR imaging in optic neuritis. And if I was wrong, please do let me know. You can reach out to me via email. So as far as I've understood, a high STIR signal means optic neuritis. But any issues, you can get back to me. Yeah, really well done to all the candidates. Sorry if I was a bit rushing you in the actual Viva. I was just trying to simulate what happens in the real exam, because the examiners, as you may know, they'll push you. But you honestly all did really well, and probably a lot better than I would have done it when I was at your stage. But thank you very much, and hopefully I'll see you guys some point in the future.